Welcome to the Metabolic MD. Health means everything. We all seek optimal health, but most of us do not know how to achieve it. Dr. Paul Kolodzik has spent a career in the emergency department. Now, he helps his patients avoid ever ending up there. During these podcasts, you'll learn how you can lose weight and prevent and reverse disease through new technology, a modified diet, and the use of some new recently approved FDA medications. This information is not meant to be medical advice. Please seek consultation from your own medical provider. Let's listen in.
Well, thanks, Kate, for let's listen in to our intro here. Dr. Paul, welcome back.
Glad to be here.
Yeah, you're always glad to be here. Where else would you be other than here? Danielle, you're joining us today.
Yeah, I'm excited to be back too.
Why are you excited to be back?
I mean, I do have a lot of other places I could be right now, but that's okay.
Well, all right. So before we get into the topic of today, which is going to be a little bit about why it's important that somebody who's thinking about going on GLP-1 might want to consider having a CGM, continuous glucose monitor, attached to their arm before, after, and maybe during, but we'll talk about that. That's
Right.
going to be the topic.
Okay.
But before we do that, we're going to thank our sponsors, which is the MetabolicMDs.com, where you can find all kinds of useful information about metabolic health. And Dr. Paul is involved with that. You actually are one of the people who provide services through there, correct?
Right. Ohio, Indiana, Florida, and Arizona are the states we can provide medical services in.
So if you're in Kentucky, you're out of luck.
Oh, I have people that drive over the border all the time.
I gotta tell you, that's one of the most stupid rules I've ever heard in my life. You can't do it in Kentucky, but you can drive across the border.
Let's talk about that. So I'm licensed in Ohio, Indiana, Florida, and Arizona.
Yep.
The medical board rules are such that the patient has to be located in the state that you're licensed in.
For the time of the service.
At the time of the telemedicine visit. So
that's crazy.
I can be on a beach somewhere, and I could be in Hawaii on a beach, but the patient has to be in a state that I'm licensed in.
That's crazy.
Isn't that crazy? Yeah.
Well,
so
right.
so that's how that worked. But I'm fortunate because I'm not bragging, but I have people that drive from Chicago into Indiana. I have people that drive from Kentucky into Ohio, which is why this came up. And also some people from California that'll fly into Arizona, do a visit in the airport, and then fly back to California.
Well, he's that popular.
He is
that's
that popular.
Super cool.
Well,
yeah.
I think we do provide a unique service that's not available. And, this whole thing started because people go to their doctor and the doctor doesn't have time to address the type of things that we talk about. Primary care docs are great at tweaking your blood pressure medicine or your diabetes medicine or whatever, but they don't always have the time to roll up their sleeves and get into the dietary and workout issues and fasting issues that we address.
Well, that is true. Okay. So the other sponsor we want to thank is CGM Doctors. Actually, CGM Doctors. That's CGM-doctor.com. So we're going to talk about CGMs, and that's why it's important. You wrote the book on CGMs, right?
Right.
Best-selling book on CGMs on Amazon. You go right now and do a search, and it's going to pop right up there. But you also are involved with providing CGMs to your door. So for people who are interested in getting a CGM, continuous glucose monitor, delivered to your door, you can go to cgmdoctors.com and sign up, and you'll be getting that CGM quite post-haste.
And that's why we put that website together, because that can be in any state. It's not restricted to the states I'm licensed in.
And you have a subscription plan too, right? So every month you can get 2 packs of CGM sent right to your door.
You can get a discount on an ongoing basis. So, and a lot of people get hooked. Once they got a CGM on their arm, they never want to be without a CGM on their arm.
You're a CGM pusher.
I guess I am. I'm creating CGM dependence, which is probably a good thing.
CGM dependence.
Danielle, by the way, thank you for joining us today.
Yeah, thank you for having me.
So you're the youthful voice. You're the hip voice of this podcast. What's going on with you before we start talking?
Well, I just have a point to make about family practice and family docs. My dad just went to the doctor. I actually went with him, and he has higher cholesterol, he has high triglycerides, all the things. And the doctor did exactly what you said. The response was, yeah, take this medicine, take that medicine, and yeah, that's about it. We'll check you in 6 months.
And they're
Nothing
so
about
typing on the screen at the same
just,
time, right?
you know,
exactly.
yeah.
Exactly.
I want to defend the primary care docs. They're in a very tough situation. We talked about this previously. You know, when I got out of my residency, it was still docs in their own little practices or small group practices. And now most of the docs are working for health systems.
Yep.
And they're scheduled. It's 20 minutes. And what they do during that period of time is put out fires related to what's going on with your cholesterol or your blood sugar. They don't have time to do the stuff that we have to do, though they would like to. You know, a lot of them, as you know, sometimes, you know, are not really super satisfied with their professional practice because they don't have the time to intervene. They're frustrated by all the record keeping that they need to do. So I want to defend the primary docs because they're you know, basically the foundation of America's medical system, and they're doing what they can, but the system has evolved such that they've become really disease management people, not prevention, or what we also focus on is reversing disease.
So, that's kind of what you do. You take the time. You're not rushing through an appointment or call. You want to hear what's going on with this guy so you get to the bottom of it.
It's structured as a different practice. You know, quite frankly, I don't take insurance because I wouldn't be able to survive doing this if I took insurance. So it's a different kind of concierge practice where we're able to provide that kind of support. And then, of course, I got the health coaches working with me, too, that are very helpful.
So it's more about
go ahead.
blaming the system.
It's just...
Is it like this in Europe?
You know, I think it's not dissimilar in Europe. You know, obviously most of those systems have governmental health care, and that has its own limitations. But yeah, it's the way this system has evolved over the course of the last 45 years. I think maybe many episodes ago we talked about my grandfather in the 40s was,
right,
you know, in a rural area, and it's like, you know, those guys were pillars of the community. They knew all the families. Well, and the other thing back then is there wasn't much technology or even pharmaceuticals
right,
that were effective. So it was really just kind of hands-on management and support. So it was a different era, and you know, it is what it is today. But that's why I think we focus on helping people empower themselves, because nobody's going to care more about your health than you yourself. And the system isn't necessarily always going to help you. And even your well-intentioned primary care docs sometimes, you know, have their hands tied in terms of the time they can spend with you and how they can help you. So it's that's why I think really that's what we're all about here, is people empowering themselves to make the changes that the system might not help them make.
Well, I mean, back when your grandfather was running a practice, they were paying him in chickens. Here's 2 chickens. Go.
We just so you guys, the listeners, know what we're talking about. It's my mom would tell me stories about my grandfather coming home with a chicken in each hand, and that was the payment for taking care of a sick child that week or something like that.
And now look at us on podcasts talking about fancy CGMs and GLP-1s and things like that. So getting to the topic, that was a long windup.
Yeah, we digressed.
As we call in the business, that's a windup. The topic is, why is it important that somebody who's thinking about getting on a GLP-1 wear a CGM before? And then we'll talk about after and during those. But why is it important that they do that before?
So I think it's important for people to have a baseline regarding what's going on with their metabolic health before they start a GLP-1. Because once you start a GLP-1, your physiological parameters like your blood glucose are going to change.
Yeah.
So if you know, are pre-diabetic and you don't know that, you start a GLP-1, you aren't going to recognize that you have that underlying pathology really going on. And so with all my patients, I encourage them to use a CGM for at least a couple weeks to see what's going on with your blood sugar, how high are your spikes, what are your averages, what are your eating patterns, how are different foods affecting your blood glucose level, because then you'll have a baseline. Because once you're on the GLP-1, remember GLP-1s are originally prescribed for diabetics.
Correct.
So they're going to lower your blood sugar, and they can give you, for example, a false sense of security regarding what's going on with your blood sugar. So I think it's important to have that baseline to start, especially if your plan is, which I think it should be, is to eventually get off the GLP-1 medication.
So but wouldn't somebody be able to go to their primary doc and get the blood work done before they get on this stuff, hopefully? And then they're going to say, hey, your A1C's 8,
Yeah.
your A1C's 9,
Yeah.
you got high blood sugar.
Yeah, and that's all helpful. Fasting blood glucoses and A1Cs are helpful, but they don't provide the detailed information that a CGM provides with 24/7 readings, where you can see exactly, a CGM is like having a fasting blood glucose every morning, because you can look at it every morning.
And I do.
Yeah. And you will understand how the different foods you eat is affecting your blood sugar levels. So A1Cs and fasting blood glucoses are great, but I think a CGM really takes it to another level in terms of providing information about your blood glucose physiology.
So while we got Danielle here, Danielle, I mean, do you have any friends who might be overweight or dealing with that issue?
Yeah.
And-
I mean, I've seen that trend. I mean, we've all seen that when younger people, 20s and 30s, increase. I mean, one of my friends she looks like she's in great shape, is pre-diabetic. I'm like, what? Because of the stuff that we're eating and because of the amount of processed sugar in our foods. And she had to go to the doctor. She had to change her diet completely. Still looks like she's in great shape, but again, she was pre-diabetic, and you can't even just tell by being overweight or not overweight anymore, which is kind of scary to me. I'm not sure if she had any sort of genetic predisposition, but
I feel like most of the time when I'm talking to this stupid microphone and we're having this conversation, I always feel like the people listening out there are in their 40s or 50s, they're overweight, and they're trying to figure out what to do. But so many people are young.
yeah.
Right? And helping them get control of their blood sugar is extremely important now, because a GLP-1 helps you reduce your blood sugar, which means maybe you don't need the CGM after that point because it's false readings, correct?
Well, once so you're getting to, so again, the process I think should be start with the CGM for a couple of weeks, understand that physiology, and then once you get on the GLP-1, your blood sugar is going to be lowered. So I do think there's probably less of a need for most people to be on a CGM as you're titrating up on your GLP-1.
Titrating means you're going from
you're
level,
going from a lower dose to a higher dose.
And you don't just start out maximum dose right away.
No,
that's what they did to me, and I got sick. And I got off it and never went back.
That's what a lot of the places are doing that don't have guidance throughout. They're just like, here you go, here are the meds.
Yeah. Well, you got to be careful related to the side effects. There's no question. But the point is, a CGM is going to be a little bit less helpful while you're on the GLP-1, because the GLP-1 is going to be lowering your blood sugar. It can lead to a little bit of false sense of security.
But is it really false? Is it false readings?
Well, no, it's not. I mean, it's really low. Yeah, you're right. But it's dependent upon the fact that you're on the medication.
Yeah.
Okay.
Yeah.
So it's understand where you're going. Take the GLP-1s. Keep monitoring that for a while, just so you can see how low blood sugar is dropping. Right?
Yeah. Now, the one instance while you're on a GLP-1 where CGM can continue to be helpful is if you're focused on an approach that I often take with my patients, which is this microdosing approach, which is trying to keep the doses very low.
And what's the benefit to that?
The benefit to that is that you create less dependence on the GLP-1.
To eventually get off of it.
To eventually get off it, yeah.
Wow.
Because again, as GLP-1s are titrated up, you really become more dependent on the medication. And then as you try and titrate down, then that's when the weight regain can occur. So my approach is try to keep those doses limited. Don't go to a maximal dose, so you can titrate down more easily.
So what is the issue? And we've talked about this in the past, but I can't remember. Let's say they figure out how to price this thing so people can afford it, right? Mm-hmm. Let's say GLP-1s become affordable. is there an issue that we just don't know about yet, that if I'm on this like a statin for 10, 15 years, something's bad is going to happen to me? Or could this just be the wave of the future?
Yeah, I think they're good medicines, quite honestly, that they can have an impact on a variety of conditions. There have been studies that have come out that shown if you have a cardiac condition, your risk of a second heart attack, for example, is decreased. It looks like they may decrease fatty liver disease, etc. But the bottom line is, do you want to start a medicine that you're going to be dependent upon for the rest of your life? Now, for some people, that may be necessary. But for people that I think are primarily focused on this medication for weight loss, not for pathological management of a pathological condition like diabetes or heart disease or fatty liver disease, if you're looking at it for just weight loss, I think the plan should be to get off the medicine, not be on it for the rest of your life.
But again, that isn't that what people we hear from all the time are saying they're going to regain that weight. So I went on this to lose weight for my daughter's wedding, and daughter wedding's over, so I can go back off and gain my weight back. All right, but your approach
People
is
don't
not
want to
that.
regain their weight, right?
But your approach is not that. Your approach is, let's get you off of it, but change your lifestyle.
Right. And so that's why I think it's important during the period of time that you're on the medications to institute the programs that we've talked about. Again, I firmly believe a low-carb approach is the best approach. It helps
Right.
you stay away from the processed foods that you mentioned, Danielle.
And I've been doing that, and I can tell you right now, it makes a huge difference. If you go to low-carb bread, low-carb everything, avoid McDonald's French fries, you're going to be way better.
Yeah. I mean, you just feel less sluggish, more energy, etc.
I've noticed too that I'm a lot less bloated. I didn't eat a lot of
I
processed
noticed that.
foods.
You look less bloated.
Thanks.
Please, listeners, please excuse Terry. So low carb, some intermittent fasting, and we're talking 14, 16 hours overnight, not days at a time. And then, of course, the critical approach of needing to be strength training. Your workouts, I think, should be 75% strength training when you're on a GLP-1 medication because you're losing muscle mass in addition to fat.
What's a reasonable amount of time for me to be on a GLP-1?
I like to, the term I always use is let's keep it to months. Let's not make it years or more, okay? I would like to try and get most of my patients off in 8, 9, 10, 12 months, right around a year, not a lot longer than that.
And they're going to lose 20% of their weight in that period of time, a year, I think is what it is.
Yeah, I mean, again, some of that depends upon if you follow a complete program. So,
Right.
I'm using lower doses, so you're going to, need to adhere to the program that we lay out, and my health coaches help people do that with, again, low-carb intermittent fasting and strength training. But where CGMs come back in as a key, we talked about, use a CGM to get a baseline. Then you're on the GLP-1. Maybe the CGM information can be a little bit less useful because your blood sugar is being lowered. But now it comes time to titrate down and off the GLP-1. And that's when CGM use can become critical, because as your dose is being lowered, it's going to make you very aware of what's going on with your blood sugar because you're getting these 24/7 readings, and it will help you guide your diet to, hopefully using a low-carb approach, as, the term people use is as the food noise starts coming back a little bit.
So again, GLP-1s kind of silence that food noise, meaning I'm not hungry. I don't feel like eating, right? If I remember the feeling, I don't want to eat that. I'm just not hungry.
Yeah. But as you know, a low-carb approach that becomes ingrained in your mind takes away the food noise as well. I mean, that's what I have experienced personally. You're shaking your head yes over there, Danielle. And I assume that's happened to you as well, Terry, that at times you don't necessarily think about the sugary foods and the processed foods as much on your mind as this low-carb approach has become ingrained.
What's funny is for me, because I'm a diabetic and my blood sugar goes low, I have to eat. I don't want to eat, but I got to go eat something. Because the CGM's telling me you're below 70, you better go eat something.
Yeah.
And I go eat something, and then I get that little small spike,
And I hope you're eating something that is generally low carb with some fiber in it.
Double stuffed Oreos.
I hope, double stuffed
With some milk.
I'm kidding. I just want to see his face.
Super high in protein. Yeah.
Yeah. No, but the low carb stuff really does make a huge difference. And if I can tell people out there listening one thing, try low carb bread. It makes a huge difference.
Yeah. Yeah, actually, I had dinner last night with a low carb tortilla.
Yeah.
Yeah, and it was. I mean, I didn't even
can't
notice.
tell.
I didn't even notice the difference. Yeah.
I mean, it costs a little bit more, but still, I mean, the carb difference is huge, and the impact to your blood sugar. If you wear CGM, you notice. Well, it didn't really bump me up much at all.
Yeah, and this goes back. I got to mention it again to the fact that we were told, because fat is public enemy number one and cholesterol is public enemy number one. Basically, we were told by the government that all the carbs in the world are absolutely fine as the basis of the food pyramid. You just have to stay away from fat. And of course, look what happened. We became a nation of overweight, largely with a high percentage of diabetic individuals. So again, I think we're just going back when we go low carb to the way people ate for generations before we were incorrectly told to just consume lots of carbs to avoid fat.
I had someone show me that government food pyramid the other day and was like, here, this is what you should be eating. And I was like,
really?
what?
They still showed that?
Yes.
Do they still? Is that still the pyramid?
Yeah, it's still that is still the endorsed.
Why isn't this Kennedy guy fixing that?
The candy guy.
The Kennedy guy. Yeah, Kennedy.
RFK Jr.?
Yeah. Why isn't he fixing that?
I think that's part of the plan.
Yeah,
I think it is.
I think he's working on that. Yeah.
Goes the hell out of that thing.
Yeah. Well, and the problem is that when the high carb approach was supported, it just gave an entree to the processed food industry. It's like, oh, carbs are fine, so that means we can basically make foods with long shelf lives out of carbs, inflammatory seed oils, and sugar. And that's what 70% of the American diet is now. So, yeah, hopefully we're going to start reining that in. But your point is a good one, Danielle. It's like there's the U.S. Department of Agriculture food pyramid, and then there's the people that embrace low carb and keto food pyramid, and they're like upside down. It's exactly the opposite. Yeah. I know you're looking at the food pyramid and you're thinking, that's the food pyramid? I eat exactly the opposite way of that.
Yep.
That's crazy. Yeah. I kind of thought that food pyramid went away. We were just talking about it from a historical point of view.
No, I think there has been actually a few years ago some minimal modification, but it's not. Yeah, I mean, and the other thing, and I'm not going to badmouth nutritionists and dietitians, but just like in medicine, things change very, very slowly. Like for a doc to start using a new procedure or a new medicine, things change slowly over a period of time. In the dietitian and nutritionist industry, the education that's going on related to that is still, very, very slowly changing. Diabetics, for example, now are still taught this exchange system.
Oh yeah,
that leads to significant carb intake.
Yeah.
And I think things will change over time, but it's going to take a while, and hopefully RFK is going to be helping that.
Yeah.
Okay.
We were taught in school. This is probably like 10 years ago. I'm showing my age. The MyPlate, which was supposed to replace like the food pyramid.
The MyPlate.
The MyPlate. I don't know. I had to do like
it's
drawings.
Just different proportions of different types of foods, right?
Okay. Yeah, I think so.
Yeah.
And that's what they were teaching us over the food pyramid.
Yeah. But the principles of the food pyramid help. And again, this all goes back to cholesterol is, for most people in the U.S., blood sugar is a much, 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 I'm going to say it again, much bigger issue than cholesterol. And I think people are learning that over time.
What are they saying about, and this might be a next podcast topic, type 3 diabetes being related to it being Alzheimer's?
Yeah.
And dementia. Like,
well, there's no question that people with higher blood sugar have an increased risk of dementia. So there's
a podcast. Yeah, don't spoil the podcast now.
Yeah.
That would be a great podcast.
But it doesn't surprise you because high blood sugar causes vascular inflammation. That's what leads to the peripheral vascular disease, the kidney failure, and the heart attack. So why wouldn't that affect the brain as well? Obviously,
Right.
the blood vessels in the brain are affected as well with high blood sugar, and that's where the term type 3 diabetes comes from.
All right. Well, we were going to end this podcast now. Danielle, as always, we want to thank you for joining us here on
Thank
the
you.
Metabolic MD /CGM Doctor podcast. By the way, we're going to be redoing all the graphics and making it look more up to date and snazzy. Expect that. So that'll get everybody excited, I'm sure. Dr. Paul, thank you for being here again today.
Thank you, Terry.
And we'll see you guys all again real soon on the Metabolic MD with Dr. Paul Kolodzik /CGM Doctor.